The disorder I chose to do my presentation on today is sexual sadism disorder. In order for an individual to be diagnosed with sexual sadism disorder, they would have to have, over a period of 6 months, had recurrent and intense sexual arousal from the physical or psychological suffering of another person as manifested by fantasies, urges, or behaviors. They would also have had to have acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies would have to cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. They could be specified as being in a controlled environment, such as a mental institution or prison, where they are unable to act on their urges, or as being in full remission, where, for at least 5 years, they have not acted on any urges with a non-consenting person or suffered any clinical distress in an uncontrolled environment. While there is no known cause for the development of sexual sadism disorder, there are a few theories and possible triggers for this disorder. Theories include psychodynamic, physiological, and behavioral theories. Some triggers include high testosterone levels, consumption of sadistic pornography, and comorbid mental disorders. It is important to note that while possible, these triggers are not known to cause sexual sadism disorder or be significantly related to this disorder. In regards to psychodynamic theories, Freud originally felt that sexual sadism resulted from the development of mental impulses based on the association of sexuality with aggression. However, most recent theorists base their opinions on parental teaching when it comes to masturbation, whether it be positive sexual education or negative punishment when caught. These theories also focus more on sexual homicide as opposed to sexual sadism, and revolve theories around displaced matricide and issues between mother and son, in addition to other issues such as chronic anger and emotional dysregulation. Because there is not much reliable and valid research to back these theories up, they tend to be just that, unreliable. Theories have also developed based on research around chromosomal, endocrine, hormonal, and neurological abnormalities among sexual sadists and/or sexual serial murderers. Because there have only been a small number of case studies and samples, this theory is also hard to be reliable and to trust. It is proposed that psychobiological features interact with social psychological features in order for the development of sexual sadism to take place. And here is where we see nurture and nature working together as opposed to being just one or the other. Early behavioral and cognitive behavioral theories of the development of sexual sadism revolve around classical and operant conditioning, where children began to associate arousal and excitement alongside aggressive stimuli, later being reinforced by masturbation, fantasies, and pornography. There has also been a proposed sensory preconditioning theory, which states that individuals have atypical responses to abuse. Whereas children and adults normally develop fear or depression from being abused, some will become sexually aroused. We tend to see abnormal responses like this in cases of certain rape victims where they become hypersexual after being assaulted. And while we are not talking about rape victims here, it is important to note again that there are atypical responses seen between many different disorders in many different cases. Because arousal coincides with their abuse, they begin to associate one with the other and are reinforced when they happen simultaneously. There is also a motivational model, which includes 5 phases of the model based on research done with sexual murderers that is listed in the handout. In conclusion, along with the other 2 theories, we see that they do not adequately explain the initial development of the disorder. And while researchers know that violent and sadistic sexual fantasies play a role in the development of the disorder, they are still unaware of how the development begins and when. Depending on the leniency of criteria, there are a few different statistics in regards to prevalence. Sexual sadism is pretty rare and is only found in 1 to 2% of the population. And while onset varies, it typically develops in young adulthood. Less than 10% of convicted sexual felons are diagnosed with this disorder, and of those 10%, 37 to 75% who have committed sexual homicides have been diagnosed. There's not much information in regards to gender in sexual sadism disorder. However, I found a statistic related to sadism as a kink. So 3 to 12% of women experience arousal in response to sadism, whereas 10 to 20% of men experience arousal in response to sadism. So it's not surprising that while both males and females can be diagnosed with this disorder, men tend to behave more with non-consenting partners as opposed to females. In over 95% of cases, those who are diagnosed with sexual sadism disorder tend to be male. In regards to culture, this disorder tends to present itself in pretty much the same manner throughout the world, and not many differences are seen from culture to culture. Because this disorder is chronic and much of its development is still unknown, treatment tends to be very hard. There are high rates of recurrence, and there's a chance that individuals with this disorder also have been diagnosed with antisocial personality disorder, which is another disorder that is very difficult to treat. Because people with paraphilia tend to be embarrassed and are typically deemed as abnormal by society, many people don't reach out for help. As I mentioned before, because most research comes from sexually sadistic homicidal offenders, this disorder may lead to incarceration, depression, loss of interpersonal relationships, as well as other disorders being developed. So there are only a few instruments used for the assessment of this disorder. There is a sexual sadism scale, which was proposed by Marshall and Hucker in 2006. In 2009, Mokros and Nish added onto the original sexual sadism scale, and here we have the severe sexual sadism scale. So this added the insertion of objects into orifices, as well as getting rid of a few of the initial criteria listed. We also have the diagnostic statistical manual, as well as the ICD. In cases of sexually sadistic homicides, they can use crime scene data, and then there's also phallometry, which is the method of assessing male sexual arousal. So a differential diagnosis would be antisocial personality disorder, and this is because both disorders share a disregard for the safety and the needs of others. And while it is a differential diagnosis, antisocial personality disorder has been ruled out because a key component to sexual sadism disorder is sexual arousal gained from inflicting pain onto non-consenting adults, whereas antisocial personality disorder disregards people more generally. And while people with sexual sadism could be diagnosed with antisocial personality disorder, and while people who are diagnosed with antisocial personality disorder could also have sexual sadism disorder, not all are diagnosed with both disorders. So there are not that many treatments available for individuals with sexual sadism disorder, and again, that is because it is under-researched. But a few of the treatments that we do currently have would be CBT, which is cognitive behavioral therapy, and here they focus on management and conditioning of arousal patterns and masturbation, as well as cognitive reconstructing and social skills training. There are also a few different medications that can be used, such as female hormone injection, SSRIs, so basically testosterone blockers and antidepressants are the most used medications. For my case presentation, we meet Tim. Tim is a 28-year-old male accountant. Over the past 6 months, Tim has been increasingly interested in abnormal sexual fantasies in which he's a perpetrator of aggressive sexual acts on non-consenting individuals. These acts include humiliating, chaining, and hitting individuals who he has complete power and control over. He becomes aroused thinking of the fear that he would put into these individuals who want nothing to do with him. He admits that his daily life has been affected by these thoughts, as he has to constantly leave his desk at work or stop what he's doing at home to masturbate to his increasingly violent fantasies. While he has not been as aggressive and dominating as he would like to be, he has acted upon these fantasies with one person prior, tying her up and taking pictures to humiliate her. So his symptoms presented involve recurrent and intense sexual arousal from the physical harming of an individual manifested by aggressive fantasies and behaviors. This is seen by him having to leave his desk or stop what he is doing in order to masturbate to his fantasies. He has also previously acted upon his urges with a non-consenting individual. Here I do make a small note that it is important that the person that he is doing these fantasies with is non-consenting, and that is because sometimes people tend to misconstrue sexual sadism disorder with the BDSM kink, but again, it's important to note that BDSM kinks are done on consenting individuals, whereas sexual sadism disorder is done with non-consenting individuals. My differential diagnosis is once again antisocial personality disorder. However, it has been ruled out because of the sexual natures of his behaviors and thoughts, as well as him doing these urges on non-consenting individuals. So my question to discuss is, after seeing the most popular theories related to the cause of sexual sadism disorder, which theory resonates more with your view on the disorder? Why do you feel that this best fits the explanation for the development of this disorder as opposed to the other theories? Thank you, and I hope you enjoyed.